Thanks very much, Carol. It's a pleasure to be here today, and thank you for the invite. And as Carol said, I'm going to talk about a dementia analytics program in Northern Ireland. And this was a large program of work that was funded by the Atlantic Philanthropies, the Executive Office and the Department of Health. And the work was carried out in Queen's University, Belfast. So I was a principal investigator on the program of work, but most of the work was carried out by the two postdocs, Alan McMichael and Evie Zaffaretti, who did incredible work and continues to do incredible work on the program. And Peter Passmore has helped along the way also. So we know that there are estimated to be 19,000 people with dementia in Northern Ireland, but this is projected to increase to 60,000 by 2050. And as a result of this, we need to understand more about what predicts dementia and to improve the quality of life for people with dementia in Northern Ireland. And you can see this exponential rise in dementia is also predicted to occur throughout the world. So again, a better understanding of what happens will help everyone. So there's lots of interest now in the use of big data and analytics on what's available rather than starting new research studies. So we were able to harness data that was available in Northern Ireland for this program of work. So today I'm going to take you through 5 projects that we have worked on. The first one is mortality rates in dementia in Northern Ireland. The second is the influence of anticholinergic drugs on people with dementia in Northern Ireland. The third one influences what causes someone to transition to a care home if they have dementia. And then we have 2 unpublished studies at the end, cancer rates in dementia and elective surgery in dementia in Northern Ireland. So how did we harness the data? Well, in Northern Ireland, we're very lucky in that we have the enhanced prescribing database. This holds information on 80 medications prescribed by a general practitioner and dispensed by a pharmacist. So in dementia, there are only 4 drugs used to treat the condition, and they're not used for any other condition. So we can use those as a proxy measure of a dementia diagnosis. The three drugs are cholinesterase inhibitors, so donepezil, rivastigmine, and galantamine. And then there's memantine, which works slightly differently. So we're able to look at a prescription of these drugs retrospectively in Ireland and look at dementia rates then. We are also able to link the enhanced prescribing database to other national databases. And we had 7 years of data from January 2010 to September or December 2016. And we linked this through the Honest Broker service, which is linked to the BSO in Northern Ireland. Where possible, we were also able to identify dementia from causes of death on death certificates or hospital admissions. And then for the cancer study, we have an excellent cancer registry in Northern Ireland, so we were able to link to that. So the first study we carried out, and it was published in the Journal of Alzheimer's Disease in 2020, was to look at what was associated with mortality for dementia in Northern Ireland. So in total, we had 25,418 people who were prescribed an anti-dementia drug over that 7-year period. Their mean age was 77.3 years. 65% of the cohort were female and 35% male, and that's really what you would expect. And at the time of analysis, 52.3% were alive, while 47.7% were dead. We found that the average survival time was 4.2 years after the date of diagnosis. And initially this seemed quite low, but it actually correlates with other similar studies that have been carried out throughout the world. Of note, 84% of our people with dementia in Northern Ireland had more than 15 comorbidity medications. So that's huge, and that's certainly something that we need to work on. So this is from the results table. It's a very busy table, but overall we found that if you were male, your mortality rate was higher. The older you were, your higher your mortality rate. If you lived in a high level of deprivation in Northern Ireland, your mortality rate was higher. If you transitioned to a nursing home several times, and if you had more comorbidity medications. People who are married had a lower mortality rate. So it's seen that if you were male living on your own in Northern Ireland with dementia, you did particularly badly. The second study then was to assess the influence of anticholinergic medication on people with dementia in Northern Ireland. So anticholinergic drugs block the neurotransmitter acetylcholine, and it's important for thinking and memory in both the peripheral and the central nervous system. Anticholinergic drugs have consistently been shown to increase mortality rates, to increase the rate of cognitive impairment in people with dementia, and to increase the risk of a dementia diagnosis itself. So through our memory clinics, we have noted over the years that the anticholinergic prescription rates are high in our patients, and we actively try them. So we were interested to see what happens in Northern Ireland to people who are prescribed anticholinergic drugs who have dementia. So we were able to use the anticholinergic burden score, and drugs are divided up into their anticholinergic burden. So how much anticholinergic activity does. So you can see that a drug with a score of 1, it has potential cholinergic effects. A drug with a score of 2 has well-established anticholinergic effects, whereas a drug with a score of 3 has established anticholinergic effects and it is linked to cognitive impairment. So we were able to look at all drugs people with dementia were prescribed in Northern Ireland, anticholinergic burden score. So what did we find? Well, we find that 15% of people only with dementia in Northern Ireland had no anticholinergic burden. So 85% of our patients with dementia have an anticholinergic burden. Most people were in the 1 to 9 score, but you can see there were 89 people who had a score of over 15. And this paper was published in Aging and Mental Health in 2020. The top 5 anticholinergic drugs were diazepam, risperidone, quetiapine. So both of these are antipsychotics. And then there was nitrite preparations and warfarin. So what did we find? We found that for people with dementia in Northern Ireland, your mortality rate was significantly lower if you had a higher anticholinergic burden score. So people on more anticholinergic drugs died sooner than those who were not if they had dementia. We also find that people who lived in areas of low deprivation had lower anticholinergic burden. So if you lived in an area of high deprivation, you were more likely to be an anticholinergic drug. And we find that specifically urological drugs such as oxybutynin, sulfenazine that people will be on for urinary incontinence, and respiratory drugs significantly increase mortality rates. So there's further work to be done in deprescribing these drugs for our patients with dementia in Northern Ireland. The next project that we carried out was what influenced the transition to a care home for people with dementia in Northern Ireland. So there's been lots of bad press about care homes in Northern Ireland for people with dementia. We were interested to see if there were any factors that predicted it and how people did. At clinic, we find that some people with dementia do remarkably well in nursing homes because they're receiving their medication regularly, they're receiving meals regularly, they're socially active. So we were interested to see what happened to our people with dementia in Northern Ireland. So we find that out of the 25,000, nearly 12,000 people transitioned to a care home. And if you were older, there was more chance you would transition to a care home if you were female, if you lived in a less deprived area, if you lived in an urban area, and if you had numerous hospital admissions, which makes sense really. We also find that people who transitioned to a care home were more likely to die there rather than hospital, which was good. And the most common cause of death now on death certificates is dementia, which again is a move forward from 10 to 15 years ago when dementia was rarely noted on a death certificate. Interestingly, we find that the mean age of people who died in a nursing home was actually significantly higher than those who lived in their own home. And again, as mentioned, you're more likely to die there rather than hospital or your own home if you're in a care home. Whereas if you never transition to a care home, you're more likely to die in hospital with dementia rather than in your own home. So there are some positives to moving to a nursing home, which again should be advocated. Now, the next study is still ongoing and it hasn't been published yet, but we were interested in cancer rates and dementia because there seems from the literature to be an inverse association between cancer and dementia. And there are various mechanisms postulated as to why this may be. So we were interested, because we have a cancer registry and because this question hasn't been answered really, is we were interested to explore if the risk of cancer was similar between people with dementia and people without dementia in Northern Ireland. We are interested to see what demographic characteristics affected the prevalence of cancer, to look at the most common types of cancer and to look at survival after a cancer diagnosis. So this study was slightly different in that the Honest Broker Service were able to match a control group for us compared to the dementia group. So you can see we have over 20,000 people in both. We started off with an age and gender match control group, but we then found that some of the control group actually had a dementia diagnosis from hospital notes and death certificates. It's just that they weren't on a dementia medication. So they were moved into the dementia group, which then meant we had slightly more males and they were slightly younger than the dementia group. We did find that less people with dementia received a cancer diagnosis compared to controls. And when we carried out a regression analysis, we showed that people with dementia were less risk of cancer compared to controls. So again, there's this inverse relationship that's been shown. What predicted who got cancer? Well, in both the control and the dementia group, male gender and older age were associated with a higher odds of cancer, whereas single people in the dementia group were less at risk of cancer compared to married people, and that is hard to explain. The most common types of cancer then were prostate, skin, carcinoma in situ, and breast. So we have further work to do on other types of cancer, but these are the 5 most common types. And we find that people with dementia were more likely to be diagnosed with prostate and breast cancer compared to controls, whereas the risk of rectal, skin, and carcinoma in situ didn't differ between groups. Interestingly, however, we find that after a cancer diagnosis, people with dementia live longer compared to controls. And again, when we carried out an odds ratio, we find that people with dementia were less at risk of death compared to controls. So we have further work to do into determining the rationale behind that, but interesting. So conclusions: people with dementia are less likely to receive a cancer diagnosis compared to people without. Older males had an increased odds of receiving a cancer diagnosis. People with dementia were more likely to have prostate or breast cancer compared to controls, but people with dementia lived longer compared to controls following a cancer diagnosis. And then the final study I'm going to present is the rate of elective surgery in dementia. So we are interested to see whether people with dementia were being discriminated against in terms of elective surgery in Northern Ireland. And we were interested in what factors predicted surgery, survival, and the most common types of elective surgery. So again, we were lucky in that the Honest Broker Service were able to provide a control group. Again, some of them had to move in the dementia group, and we had a slightly younger and more male cohort in the control group. We did find that significantly less people with dementia were referred for elective surgery. So this is hip, knee replacements, cataract surgery, etc., compared to controls. And dementia diagnosis was associated with a lower odds of having elective surgery. What were the predictors then for elective surgery? Well, the younger you were in both groups, if you were male and if you lived in your own home compared to a care home, increased the odds of having elective surgery. So you can understand the younger age and living in your own home for elective surgery, but why more males than females? Single people were less likely to have elective surgery compared to married people, and is that because they don't have someone to advocate for them, perhaps? So we found the most common elective surgeries were cataract surgery, skin surgery, and heart surgery. And again, we have further work to do on other types of elective surgery, but these are the results we have to date. So we find that significantly less people with dementia had cataract or heart surgery compared to controls, while they were more likely to have skin surgery. So the cataract surgery is a concern. We can understand perhaps why people with dementia aren't referred for heart surgery if appropriate, but we know visual impairment can contribute towards cognitive impairment. So people with dementia should really be offered cataract surgery. So there's further work to be done then. Interestingly, we also find that having elective surgery was associated with less risk of death for people with dementia and controls. So there's no evidence that surgery increases death rate in people with dementia, which again is reassuring and should provide us with some ammunition, especially for cataract surgery rates. So that's really the conclusions on that study. Limitations then were that we were limited by only people who were prescribed dementia medication. So there will be people who can't tolerate medication or who have contraindications to it and aren't prescribed a cholinesterase inhibitor or memantine. There are other types that won't be included, such as frontotemporal and some vascular dementias where these medications aren't prescribed. We also can't tell the type of dementia from the prescription rates, and we can't tell the severity. So there are limitations to our work. We also had no record of over-the-counter medications, which can have a high anticholinergic burden, for example. So again, that's a limitation. But at the same time, we were able to analyse data from over 25,000 people with dementia in Northern Ireland, which provides useful results. So other projects then are antipsychotic and antidepressant-inducing dementia, the management of myocardial infarction in dementia, the difference between early and late onset dementia in Northern Ireland, polypharmacy and then hyperpolypharmacy, where people are prescribed more than 10 drugs, and then the hospitalization rates of dementia. And then that's another, living alone with dementia was another paper we have published in 2020. So further work to come, and a huge thanks to Alan McMichael and Evie Zaffaretti, especially, who continues to work on this even though she's moved on to another job in Cork. And we've been significantly hampered by the COVID pandemic because the BSO was closed for a long time, but I must say Alan and Evie did incredible work throughout that whole time. So thank you very much. And thank you very much to the BSO and the Honours Broker Service for enabling us to carry out this research. And a huge thanks to the funders. Thank you.
Thanks very much, Bernadette. There were some very interesting studies and a nice kind of summary of each one. Thank you. And just a reminder to people who joined us that you can use the chat and Q&A buttons there on your screen if you have any questions or comments that you want to make. And we'll have a 10-minute Q&A at the end. Okay, so our next speaker then is Dr. Frances Duffy, who's Consultant Lead Clinical Psychologist at the Psychology of Older People Services, Northern Health and Social Care Trust. And Frances is going to talk about using dementia assessment data and machine learning to support timely differential diagnosis. So over to you, Frances.
Thanks, Carol, and thanks for inviting me here this morning. So as Carol said, I'm going to be talking about how we use dementia assessment data from our memory service and apply machine learning tools to support timely differential diagnosis of dementia. So I work with a kind of large team. There are two parts to this team. There's a team that were involved in the data interrogation, which is staff from the Northern Trust and also Ulster University. And then there were a team that developed the algorithm and the dementia assessment app. And that was again working with myself, Nightingale Analytics and Ulster University. We were funded by the Dementia Analytics Research User Group, DARAG, funded by the Health and Social Care Board, Northern Ireland Executive Department of Health and Philanthropy. So thank you to them for their support to carry out this work. So what we wanted to do was we wanted to try and understand the different profiles and the different outcomes of people who attended the memory service in the Northern Trust. And then we wanted to create a dementia assessment app to see if we could support diagnosis in this way. And if we look at the the reason why we want to promote timely diagnosis, because this leads to better adjustment for the person. It can lead to slower progression of the condition. It enables the person to plan ahead when they're in the earlier stages, and it also actually represents health and social care savings. So where our data came from is that we looked at data from everybody who attended the memory service between 2013 and 2019, and this resulted in almost 3,000 assessments. And some people will attend the memory service and they don't have a diagnosis of dementia, and they may come back again at some point later, and then they may receive a diagnosis at that stage or may not. So we had over 2,700 unique assessments, and then we also had 183 people who returned for a further assessment, either one assessment or one further assessment, 2 or 3 further assessments. And I can talk a bit about the importance of that at the end if we've got time. And we had 75 separate features. So what we did was we looked at all of the questions that we ask as part of the memory service assessment. And that's what we based our analysis on. So just to give you a flavour of the features, there's lots of general features in terms of education level, age, gender, occupation, etc., what medication the person's on, whether they've got a package of care, etc. And then the symptoms that the person reports, such as insight, progression of the symptoms, sleep problems, hallucinations, delusions, etc. We complete psychometric measures. So we use the Addenbrooke's cognitive exam, which is a brief cognitive screen. We also look at the Bristol Activities of Daily Living scale and the Zarat Burden interview for carers. And then we look at physical health risk factors as well for dementia. And there are a number of these are included. So if we look at who attended the service, 62% of the people attending were female and 38% were male. In terms of the average age of people attending was in their 80s, but we had people who were in their 40s, and actually we had people who were over 100 as well. If we look at the potential outcome of an assessment, so someone's referred to the memory service, they get a cognitive assessment, and then they're either a diagnosis or no diagnosis. And the diagnosis of dementia could be Alzheimer's disease, vascular, mixed, unspecified, Lewy body, frontotemporal, and some of the other rarer dementias. And then people may also be advised that they've got a mild cognitive impairment, or the diagnosis may be uncertain. And the data that I talk about is really, we're only going to look at Alzheimer's, vascular and mixed dementia and mild cognitive impairment. And the reason for that is that we had less numbers in these other dementias, but we're collecting data ongoing. So we will, as time goes on, have more information about the profile of the other dementias. We also had a control group, and the control group were people who didn't present to the memory service. They had no diagnosis of dementia, and they were recruited through social media and drop-in centres in the local community. So the outcome of the memory assessment, what we find is that 22% of people that attended the service had a diagnosis of Alzheimer's disease, 18% mixed dementia, vascular dementia, and then to a lesser degree, some of these other less common dementias. Interestingly, 27.5% of people ended up with a diagnosis of or were told that they had a mild cognitive impairment, and 14% had no diagnosis. And the no diagnosis may have been people who had a mental health condition that presented with some features or symptoms that may be similar to a dementia, or it may be that they were actually very well and no physical or mental health conditions, but they were worried about their memory. So what I'm going to do is I'm going to present very briefly just some of the data that we looked at. And again, we have a paper on this, and I could discuss it more if people were interested. So if we look at the ACE scores, well, the cutoff for the ACE score for a healthy control subject is 88. So you can see that our control subjects were within the sort of the average range of scores in the Addenbrooke's. You can see that people with a mild cognitive impairment perform slightly worse than control subjects, and mixed dementia worse than the controls. But just looking at this box plot, there doesn't seem to be a significant difference really between the 3 different types of dementia, which would suggest that ACE3 scores in themselves, the total score, isn't good at differentiating between the dementias. And if we carried out a series of pairwise comparisons in all of this data, and you can see that the ACE total score doesn't help us differentiate between what type of dementia that somebody has. However, mild cognitive impairment perform better than all of the dementias, and the control subjects perform better than all of the other groups, including the mild cognitive impairment. So what we did was we interrogated the data a bit further, and we looked to see, which of the domains of the Addenbrooke's might be predictive of the different types of dementia. So within the Addenbrooke's cognitive domain, you've got domains of memory, attention, language, fluency, and visuospatial function. So we were interested in is if we look at any of these domains, do they help us differentiate between the different types of dementia? So we can look at things like fluency, and you can see just from this box plot that the fluency scores look slightly higher in Alzheimer's disease compared to the other two types of dementia. So we applied pairwise comparisons to all of these domains to see what significant effects that we got. And we can see, if we just even look at language, we can see that language ability is significantly different in Alzheimer's disease compared to vascular dementia, but it's not significant for the other two dementias in the group. So through a series of pairwise comparisons, we can look to see if we can predict any of these patterns, so that when someone comes to clinic, we can look to see whether or not the patterns will help us to make that differential diagnosis. But other things that were important in this data as well were the questions that we asked the attendees. So for example, does the person have insight into their difficulties? Are they aware that they've got cognitive impairment? And what you can see is that for the three types of dementia that we included, there was very little insight. So very few of the participants had insight into the fact that they had cognitive difficulties. Whereas someone with a mild cognitive impairment, as you would expect, actually had insight into the fact that they were experiencing difficulties. So these types of questions can help us to understand about the different presentations and what the person's diagnosis may be. And also, if we look at impairment activities of daily living, what you can see is for the three types of dementia, that there was a significant amount of people who actually reported impairment or experienced impairment in activities of daily living, whereas someone with a mild cognitive impairment was less likely to have impairment in activities of daily living. So with all of the data, we've published our first paper on this in the European Journal of Aging. And what this is, it presents data then in all of these patterns that we had across the domains of the Addenbrooks to help us determine whether the Addenbrooks was good at predicting different types of dementia. But what we're also interested in is, can we use this data to help clinicians to make decisions about diagnosis? Because what we know is that we've got all of the cognitive assessments, but we've got all of the other information that clinicians have. And what we think happens is that clinicians weight each of these decisions mentally. They weight them as in what piece of information is more or less important. And they complete these kind of complex calculations in their brain that actually gives them an impression about whether someone has a dementia and what type of dementia that they have. So what we were thinking was, well, can we use this data to actually help us predict what type of dementia someone has? So what we did was we used machine learning techniques. We applied this to the data to build a predictive model to support clinicians to make a diagnosis. And we've been building on these models as our data has continued. And we've come up with our latest model, which categorizes into two separate slots, first of all, people who have cognitive impairment versus people who have non-cognitive impairment. And the sensitivity, as in the ability to detect a real case, is 82%. And the specificity, and that's the ability to select a non-case, is 85%. And the overall accuracy is 82%. So we're doing not too bad in terms of that predictive model. And then what we do is we look at dementia versus non-dementia. So this is really the ability to differentiate between, the dementias and the mild cognitive impairment. And again, the sensitivity here is 76%, specificity 72%, and accuracy 81%. So again, it's not doing too bad, but we're looking at more data as we go along so that we can actually increase this. So the more cases we have, the better the model will be at predicting the different types of dementia. So what we did then was we took our paper and pencil assessment and we digitized it. So we developed an app that enables us to capture then the data ongoing, and it validates and stores this data so that we can put this data into the algorithm to improve our diagnosis. So I'm going to give you a brief demo. I'm just going to stop sharing a second, and I'm going to give you a brief demo of the algorithm. So what we have is we put our all of the information about our referrals in, and then we can ask various questions from the algorithm. So we can look at things like personal history. Can the person recall, where they were raised, where they were born? Yes, no, or unknown. We can ask about where they can recall information about where they retired, Can they name their parents? So this gives us information about their ability to recall their past. We can ask, we can record information about the person's presentation. You know, were they well presented? Because they concentrate during the assessment, etc. We can ask things like, are they repetitive in conversation? Are they misplacing items? We can ask this of the person, and we can ask them of the carer. We can ask about impairment activities of daily living in terms of their ability to take their medication. So we complete a comprehensive review. We also have information about their mental health history. We have information about just their general well-being in terms of whether they use hearing aids, etc., their eyesight during the assessment, and then questions about their physical health, their history of falls. So what we've done is we collect all of this information. All of this information is stored then within our app, and the app then gives a prediction about whether or not the person has a dementia and what type of dementia that they have. So we're currently piloting the app within the Northern Health and Social Care Trust, and we're applying for, in the process of applying for MRHA approval for the use of the algorithm within the app. And that's going to take, you know, a few years down the line. But again, the first data being collected is currently being collected through the app. And just while I'm here, I just wanted to very briefly mention another app we have, which is the Clear Dementia Care app, which is an app for carers and care staff to help them understand dementia and suggest helpful ways of responding to the person with dementia. And that's free to download on the App Store and Google Play. So just want to say thanks to the Health and Social Care Board, the Northern Ireland Executive, Department of Health and Atlantic Philanthropies for their support with this project. Thank you.
Thanks very much, Frances. That was a very interesting talk and really interesting to see all that work going on with the apps. So just a comment there from someone, really interesting, thank you. Somebody just asked there, they may have missed it, but what is the model or the algorithm behind the app?
Okay, so I'm collaborating with Nightingale Analytics, and not being an expert in that, I would be able to get you more information from that. If I can get your email address, then I can get our the developer who's working on the algorithm. It's not my area of expertise, so I probably not be comfortable talking about the actual algorithm itself.
Yeah, no problem at all. So if that person wants to maybe email me, and then I can link them in with yourself, Frances, and we'll get that information for them. Great, thank you very much. So we'll now move on to our final speaker, who's Paul Carlin, a staff tutor and researcher at the Open University. And Paul is going to talk about healthcare analytics for dementia across the island of Ireland. So over to you, Paul.
Hi everybody, and thanks for coming along. Hopefully you'll find some of this interesting anyway. And as the other two speakers have alluded to, we were involved in the dialogue program as well. So the same group of funders, and we're part of that project. And what we did, we had a sort of different approach, I suppose, in that we looked at an established data set and then looked at that and for patterns in terms of the data analytics. And then we also had a separate strand around PPA. And what I'll do just here today is just look at the PPA and speak to some of the data analytics, but I'm not an expert, and this has been prepared by colleagues in terms of data analytics, but I can get further information if needs be. And just some of the outstanding challenges that we found, particularly around COVID and around the PPA work. But just as a brief overview, we had access to the Tutor data set, which was a conglomerate between Trinity University of Ulster, or Ulster University is now, and the Department of Agriculture. And basically that looked at about 5,200 participants, older adults, recruited right across Ireland, the Republic and the North. And then they were followed up 5 to 7 years later, and it looked at a wide variety of indicators. So we looked at diet and lifestyle, and basically what we were looking at in terms of our project was there any sort of patterns in that we could look at that might have major impacts or influence in terms of predictors later on, and how maybe small modifications and those sorts of things might actually help prevent or manage some of the issues in and around dementia, as it is, as we know, somewhat of a challenge. So we had two strands really. We had the analytics and the algorithms and the technical work that went along with examining the data set and looking at how we could use that in terms of these predictors. But we also wanted to include a wide variety of participants and actually looking at what we wanted to do. And that was the PPI strand really. So we looked at representation from charities, from carers, from people with dementia, and also professionals within that sphere. And what we tried to do was run some scoping exercises about the work that we were doing, the data set that we were using, and what might be achievable, or what they thought might be workable, or wanted in this field going forward. So to try and almost, I suppose, involve people in setting the agenda. And that was one of the things that we wanted to examine. So what we did was we looked at building 3 sessions. We had about 90 participants across all 3 sessions, and they were spread throughout Northern Ireland. So we geographically, I suppose, we got a reasonable spread in terms of organisation, and each of those sessions followed a very similar pattern. So that the team, we gave them an overview of the data set, the analytics, and how that might or might not work, and then also some of the technology that might be used in terms of managing that and driving forward our understanding of the data and the predictors potentially it was in that, and how that was going to, how that methodology might work as we move forward. And then what we wanted to do was follow that up at regular periods to inform the group and actually get a feel for what they thought in terms of the direction of travel for the project. So in terms of the broad or the more detailed sort of look at what we did in each of the groups, we just asked 2 questions. And we did this using an innovative technology that Ulster University have developed called Engage. And basically what that is that each of the small groups are set up in a round table sort of fashion. And then what happens is you have a moderator with some technology at the table, and that's fed back to a top table who just manages the discussion. Basically, it's coming back from each of the tables. That then is presented in a form for people to have further discussions and refine, and then that is produced as a report at the end of the session. So it all happens in real time. People can discuss it, they can refine it, and it really is reflective of the discussion that goes around the table. The moderators, they moderate, basically, they capture what is being said, and that's driven by tablets, I suppose. And what you do is you end up developing themes, so and areas that are interest to the overall group. So we asked 2 questions really. So what were the important factors in terms of causes of dementia, and how potentially this project may or may not make a difference on what we should maybe concentrate on. So basically, as we moved through the process, we were able to generate word clouds, and as you can see, what we did was then we broke it down and then looked at what the general discussions and how many times people were actually talking about these and exploring these sorts of themes. And these were the themes that we found in terms of that first question. And as you can see, it was quite broad, but there was a pattern that developed, and across those, we looked at, and in terms of mind mapping, we could look at the relationships between some of the discussions that were going on, and they were analysed. And what we could see was that across all these, we were looking at lack of stimulation seemed to be an issue, lifestyle activity in terms of driving prevention potentially, and stress genetics. And when we explored those factors that they thought, again, that really drove risk to dementia, again, genetics and this notion of isolation, stress, and lifestyle were very predominant, basically. And so obviously for us, that was quite useful to look at that. In terms of the second question, what we seen again was that, you know, how would this project make a difference, or potentially what should we be concentrating on? And key themes kept on developing in all of the discussions right across the board, lots around education, research, and planning around services, and being proactive in terms of that, and moving into the future. So in terms of our overall identified priorities, so basically, I suppose people were wanting to have an understanding, be able to encourage and stimulate people, both cognitively and physically. So exercise was coming out as a key theme, and also raising awareness. These were you know, themes that were discussed across all three groups, and that really results in a notion that planning, education, which obviously includes research and prevention, are really key domains for anybody that's working in this sphere. So with that, obviously we have this data set. We have, you know, when it's quite a large data set, we're looking at, you know, predictors then and prevention potentially. So I suppose what the analytics team did was that they looked at that. They used an R-bands, which is a cognitive function tool, which gives an indication of cognitive performance. And they used a lot of mathematics and a lot of technical wizardry, I suppose. Again, it's not my field. And what they did, they looked at three different classifiers to classify the R-band score, and then look at that to identify key nutritional and maybe environmental predictors for cognitive performance. The R-band scores sort of can take a bit of time. It can be a quite complicated thing. So I suppose they're looking to simplify this. And so in terms of those outputs, their models perform very well against that R-band score. So, and things that seem to come across well, particularly the TUG score in the domains. So that age of when people stop their education, and whether or not the participant's family reported memory concerns. And also in terms of the decline, so it's not just about, you know, overall predictor, but also in terms of the decline in terms of the R-band score. So there was some blood indicators, so homocysteine, B6, and glycated hemoglobin. So those were really interesting sort of results that came out of this. And therefore, the potential here is that rather than having maybe more complex sort of assessments, you could have something that's much more quick, non-invasive, to help decide whether a patient requires a further a battery of tests or investigations at certain stages in this process. So, you know, what's that classification and categorization of risk, I suppose? So we have a quote here from a consultant geriatrician, and they found that the published paper and JMIR was that, and I'll just read, I suppose, that the paper's fascinating. Education being a factor in R-band scores is to be expected, but the involvement of TUG as a factor in both cross-sectional scores and rate of change, and B vitamin and homocysteine and rate of change, are very interesting. TUG was the only factor involved in both cross-sectional and rate of change of R-band score. As TUG involves both frailty and muscle strength, its association in predicting cognitive scores and change of scores is very interesting. I suppose that's the thing here, is that for this data set, you know, it's there. There's lots of work that we can actually look to refine this, and this is probably not maybe the only pattern that will be involved in this. And what it does, I suppose, lend us is the opportunity to build on work that's already been done and actually refine that. And we can maybe look at this going forward, particularly with the follow-up data. So there are a few outstanding pieces to the work that we've done. So the plan originally was, in terms of the PPI, that we'd have continuous engagement. Now there was two issues with that. One, there was definitely an attrition in terms of interest as we moved through the project. Now that could have been because of the methods that we used in terms of keeping in contact with our participants. So that may be something that we need to look in terms of refining that PPI engagement and also feeding it back and making it meaningful within the project. And also, unfortunately, we had COVID, which hoved into view as we were planning to do an end of session or an end of project review with participants, because what we wanted to see particularly was whether their expectations that we set on the original engagements had been met. So had we, did this really meet what they thought would be the outputs of the project? Because from our perspective, we have a certain perspective in this, but it would be very interesting to see on a further reflection from the groups that have been involved in the original work in terms of the PPI, whether they thought we'd actually met the brief. Obviously, I wrote some questions, and that's the final slide for contact details and resources.
That's great. Thank you very much, Paul. That was a very interesting talk there, and nice to hear about the PPI workshop. So I think from the three speakers, a nice kind of broad sweep of different types of research using data analytics. So really interesting to hear all the different, lots of activity going on in Northern Ireland. And thanks for sharing that slide. So you can see some of the resources there, the Alzheimer's Society of Ireland in the Republic and in Northern Ireland. We have our Understand Together campaign in the Republic that people can look at. That's for the Republic to reduce stigma and increase awareness around dementia. We have dementia pathways for healthcare professionals. We have our own website, and you see our Twitter handle there if people want to follow us on Twitter. And as I said earlier, the recordings of this webinar and previous webinars will be on our YouTube channel, so people can look that up. And just to mention as well, the next webinar we'll have is on the 28th of February, and that'll be on vascular dementia. So it's the same Eventbrite link that you used to book this webinar. You can use it for that one as well. So there's a question came in here for all, open to all speakers. So feel free to jump in, whoever wants to answer this. In deploying a data analytics approach for your work, what have been the opportunities as well as barriers? That's a good question. Yep, so Bernadette.
Thanks, Carol. I suppose the opportunities have been the infrastructure that are available within the Honest Broker service and the access to the enhanced prescribing database for us, and also the opportunity from them to link to other data sets. So we could link with the data warehouse who hold information on hospital admissions, for example. We could link with the cancer registry. So all of that took time, obviously, and data access agreements, but we got there in the end. So I think that's a huge bonus. One of the barriers in Northern Ireland is, as yet, we have no access to GP data. So this would have been a much more informative project, for example, if we'd known the different types of dementia people had, and had access to clinic notes, for example, to tell if they had mild, moderate, or, for example. So that's one of the barriers, but there is work being done on that to develop a GP platform, which will be excellent when it's rolled out. And I think all of us were impacted by COVID-19. So the Honest Broker service was closed for months and months and months, reopened shortly, was closed again for months and months. So that had a huge impact on the two postdocs who were working within the project, who were on time limited contracts, obviously. Yeah. So that's my input.
Great, thank you very much.
You.
And Frances, I might go to you next.
Thanks, Carol. Yeah, I suppose in terms of the opportunities, I think the fact that we had the funding available from DARUG really enabled us to do this. So we had all of the data that was sitting around in files, but if we hadn't have had the financial support to employ people to actually access the data, then obviously that would have been possible. But I think really the collaboration, and I think between collaborating with industry and the university and health was essential, because we had the experts who were able to do the data science for us in terms of the university, and then the algorithm in terms of industry and the app. So that was a real kind of opportunity. And then I guess also in terms of how do you put something like this into clinical practice with the app, the fact that we had the regional dementia care pathway in Northern Ireland, and we were trying to move towards greater relationships between GPs and secondary care, primary care and secondary care, the fact that we could actually move some of our assessment within primary care was a really good way in which the trusts were able to build into piloting the app within our service.
Great. Thanks, Frances. And Paul, you want to add?
I think it sort of builds on what the previous two speakers have said. This highlights the importance of having a digital infrastructure in and around clinical information and actually linking it all together. You know, we've talked about GPIP there, but and the honest broker service, but it's working in harmony to actually meet the requirements of what's needed in terms of offering indicators for good care and for interventions. And the only way we can do that actually is by freeing up this data. And it's not just in terms of the public sector, but we also need to involve the private sector, as Frances rightly said. So these projects act as exemplars of how that can actually work. And there's a lot of bad press in and around how data should or should not be used, and people want to be very protective. But, you know, there are systems and processes in place now in terms of good governance. And whilst I appreciate sometimes it can be hard to get stuff out of the honest broker service, it does act as a quality measure in terms of governance. So that actually acts as a metric of performance in terms of safety. And that's something that, you know, we should be starting to embrace and actually building upon, and linking these data sets much and integrating our care data much more robustly, so people can actually do this sort of work, because it's the only way we're going to actually meet some of the requirements for people's care moving forward and policy decision making in the future.
Great, thank you, Paul.